Thank you, Dr. Fawaz. Thank you, Dr. Abdullah, Dr. Musa, for the invitation. I'm going to try to bore you with this dry talk a little bit, but we're talking about cardiogenic shock and mechanical circulatory support devices. We know that most two important things that we focus in cardiogenic shock, the two things that mostly happen is vascular congestion and also lack of perfusion or hyperperfusion. So I'll be talking about different mechanical circulatory support devices and the effect on those two things mainly. So we know that inotropes and pressors may buy you some time, but if we think about pathophysiology, these things will actually make heart recovery even worse and will increase myocardial consumption. We have multiple circulatory support devices available for us now, and we have different combinations of those devices. We talked about SCAI classification, we talked about cardiogenic shock. Early recognition is key. Now, we're talking about those devices to implement in a timely manner. No mechanical circulatory support will be of a help on a dead patient. When you are in stage E with multi-organ failure, it doesn't matter if you put them in ECMO, ECBella, 5O Impella, doesn't matter. It's too late already. So we're targeting those patients at stage B and C and trying to prevent the progression of shock to multi-organ failure. I'll be talking about pressure volume loops, but just to kind of give you a rough idea, what do we mean by that? If we go back to physiology, it's just an implementation of one cardiac cycle. This is the catheter that we use to measure pressure volume loops. So it's a catheter that sits in the apex of the LV, has 12 electrodes on them, and then we measure the amount of conductivity of the blood, how much electricity is hitting from one segment to another, and that creates by itself a volume. And the sum of these volumes together will give us the actual pressure volume loop that we see. That will look like this. So if you look at this pressure volume loop, it has four components. The first component is the isovolumetric contraction. And then the second component is the ejection phase. The third component is the isovolumetric relaxation. And the fourth component is the filling phase. We'll be talking about a couple of different things with stroke volume and potential work. The natural relationship is the increase in volume will increase contractility and will increase pressure. So this is the healthy heart that you see on the right. Increase in the diastolic pressure will increase the contractility and will result in increase of the pressure. What happens in, for example, a stiff heart is you get this area here, you get like a much higher pressure elevation with smaller volume. That's what happens with diastolic dysfunction, stiff ventricle, things like that. In a remodeled heart, you will have much higher volume before you get the same amount of pressure. That's when we talk about the cardiac cycle present the stroke work, and then the left to the stroke work is the potential allergy. And all that, it's called pressure volume area. So the pressure volume area is directly related. The higher it is, that means that more contractility or the more myocardial consumption that happens to produce that pressure volume area more. That's what happens with a sick heart with reduced ejection fraction. You will have that loop shifted to the right. So you'll have higher end diastolic pressure, and then you'll have less of a pressure change with the same amount of volume. The more PVA, the more O2 consumption, the more calcium cycling that the heart will need. Now we come to the different devices we have. The most four common devices that we have is the balloon pump, LV, axillary pump like an Impella was a 3.5 or a 5.0, the tandem heart, and also the VA ECMO. These are the different configurations that you get those devices in, whether it's right-sided or left-sided. This is a quick example of how does the balloon pump help in shifting that pressure volume loop. You can see that with the balloon pump on, that loop is shifted more to the left. So it's less congestion, less LV EDP, and less pressure on the heart. So this is just a dynamic show of how the balloon pump, when it's on, how the pressure volume loop is shifting to the left of the screen. So less PVA, so less myocardial consumption, less stroke work for the heart. So, and we know that, balloon pump will drop the wedge a little bit. It will increase the cardiac output probably by 0.5 liters. What's going to happen with an Impella? With the Impella, you'll see that PV loop is becoming more shifted to the left, so less myocardial consumption, and you'll find it's more triangular. So you'll have more blunting of the isovolumetric phase of the diastole and also the systole. So that's what we call resting the heart, or the venting of the heart. The pressure actually will drop down, the pulsatility will come down, but also the volume will shift. So patients on Impella, they will have less myocardial consumption per minute compared without the Impella. You'll see this is what happens. This is an actual patient actually I did when I was in the States. This is a patient prior to PCI. We put the pressure volume catheter in, and high-risk PCI patient with an EF of 25%. This is initially the Impella on P2, and then we are going to P8. So you could see how the change of the LV pressure is coming down, the pulsatility is coming down, and also at the same time, the flow of the Impella is going up, and the LV volume is going down. So when we went from P2 to P8, you could see the effect on the different hemodynamics of the heart. The loop moved significantly down to the left, so less volume, less tension, reduction in the preload, and also less myocardial consumption. This is what happens with tandem. Tandem, it's a modification of ECMO, extracorporeal device. The only difference is the cannula is in the left atrium. So with the tandem, you'll see increase in the blood pressure because you're increasing your systemic vascular resistance, increasing the cardiac output, and reduction in the wedge. So the loop becomes narrower and higher. So the pressure is higher. It shifts a little bit to the left, but not that much because, again, you are not emptying the LV. You're increasing the afterload. So that's what happens with the tandem. Now, when we go to ECMO, ECMO, what happens with ECMO is you are pressurizing the whole arterial system. So you're working against a high afterload. This is what happens with simple preload change in a normal heart. The pressure will change, the LV pressure will go up. What happens with the fixed pressure is the volume will change with no change in the pressure. And that also translates when you have a sick heart. That's what happens when the aortic valve is not opening. So this is what happens, the same thing what happens with ECMO. You are increasing the afterload. You are also increasing the preload. So actually the pressure volume loop will shift to the right. So you'll have higher EDPVR, you will have higher pressure, and the actual O2 consumption by the heart is actually higher. So when we are putting a patient on VA ECMO, you are actually challenging the LV. You are putting more work for the LV. So you think about that, if you have a very sick LV and you're putting someone on VA ECMO, you're actually adding more work on that sick LV already. You're increasing your LV EDP, you are increasing your PVA, you're increasing your stroke work. So Okay. So that's the whole point of venting the LV. When you have a very sick heart,
2 minutes extra, please.
when you have a very sick heart and you put patients on ECMO and cardiogenic shock, CPR, patients with bad anterior MI, completely stunned myocardium, bad myocarditis, the LV is not doing anything. I've seen it where LV thrombosis, the aortic valve is not opening at all. And one of the configuration that can be done is something called LAVA, which is left atrial ECMO. You put the instead of putting the venous cannula in the RA, you cross to the left atrium and you put the drainage cannula in the left atrium. And that will decrease the preload and it may help venting the LV a little bit. So actually there's a bunch of case series about patient on LAVA ECMO where you use only one support device instead of two. And that may be enough, but a lot of those very sick patient, bad cardiogenic shock, completely stunned LV, that's the whole concept of the Acapella, is to give the heart a chance of recovery, vent the LV, prevent the thrombosis in the LV when you have a very high afterload and the aortic valve is not opening up. Thank you.